We are continuing with our series on opioid use disorders. So, opioid use disorder is what we are talking about today. So, mental disorders, within that bigger picture, substance use disorder, within the substance use disorders, opioid related disorders, within the opioid related disorders, which have many disorders, we are specifically talking about opioid use disorder. All this is Dr. Mubin Sayed. We are continuing with our series on opioid use disorders and pain management. So, the discussion today is actually the opioid use disorders. So, let's start our discussion. First of all, I want to ground ourselves to where we are in the discussion of the topics. So, from the DSM-5 text revision, from that book's point of view, and that is a correct point of view, first of all, we have mental disorders. Within the mental disorders, there are many, many types of disorders. One of those types is the substance use disorder. And we talked about that last week, that in the substance use disorder, we have more than 10 substances that we can talk about, and we can have their disorders, except caffeine, although it is part of the substance list as well. Then within the substance use disorder, one of the disorders is opioid related, not use, opioid related disorders. Within the related disorders, then we have many types. For example, opioid intoxication disorder, we have opioid withdrawal disorder, and similarly, we have opioid use disorder. So, opioid use disorder is what we are talking about today. So, mental disorders, within that bigger picture, substance use disorder, within the substance use disorders, opioid related disorders, within the opioid related disorders, which have many disorders, we are specifically talking about opioid use disorder. Now, I also want to quickly have you have a look. This is the DSM-5 TR. Of course, it is copyrighted to American Psychiatric Association. It is available online as well to buy. So here, if you see opioid related disorders, in which we have opioid use disorder, intoxication, withdrawal, induced mental disorders, unspecified opioid related disorders, and so on. So there are multiple within the related disorders, and we are talking about one of them, opioid use disorder. So with this, now let's go to my presentation. So I have no disclosures and I have no conflict of interest. Objectives. So the discussion that we'll do today, we'll talk about the prevalence of opioid disorders and opioid usage and heroin usage. Then we'll talk about the 11 diagnostic criteria. You would see that within the substance use disorder, as we discussed last time, there are 11 criteria that are used for the diagnosis. So of course, we're talking about within the substance use disorder, we're talking about opioid use disorder. So we'll have 11 criteria for this as well. So we're going to go over those criteria. Then when are those criteria not met? Or when is a specific criterion not met? I'll spill the beans right now. We know that tolerance and withdrawal, if these are the only criteria that are observed or only symptoms that are observed while the patient is on an appropriate medical prescription, then these are not counted. Then we'll also talk about severity assessment, mild, moderate, severe. Then we'll talk about the specifiers of the opioid. Then we would look at the ICD-10 codes as well for how do you, when you diagnose a patient, how do you code them? And so then we'll talk about diagnostic markers, and then further reading, which is DSM-5 TR is the most important further reading. So starting with the prevalence. Source of this information is DSM-5 TR. So in the US, adults age 18 and older, the prevalence of non-medical prescription-based opioid use, meaning people using opioids outside of the medical prescription, is 4.1% to 4.7%. 12 to 17 years, adolescents, the prevalence in them is 2.8% to 3.9%. And 18 to 25, 5.5%. 26 and older, 3.4%. What is the basic message here? Young adults have the highest percentage of opioid usage outside of the medical prescription. Adolescent also have opioid use. However, in them, the younger they are, the less they use. And as they start going up the age, they have a higher prevalence of opioid use. On the other hand, heroin use within the US is 0.3% to 0.4%. And 18 to 25 is the highest use group, and that is 0.5% to 0.7%. Heroin usage in adolescent, that is 12 to 17 years, is quite low. It is like lesser than 0.05% or even lesser than 0.1% based on the age. Then is the prescription opioid use disorder. So here what we're talking about is somebody who was prescribed the opioids, then they use the opioid, then they develop the disorder. So in there, US adults age 18 and older, the prescription opioid use disorder is 0.6% to 0.9%. 12 to 17 or adolescent, 0.4%. And heroin use, so you could say that is their prescription of heroin. So it is the individuals that are prescribed opioids, then they became used to opioid, and then they found heroin as well, and that disorder appeared. So 0.1% to 0.3%. Heroin use in adolescent is essentially equal to 0%. It is so low that it is, the DSM-5 TR uses the word essentially 0%. Correct. So Uzi says, I guess that is not a longitudinal research, so that it is influenced also by changes not only in the age, but also in the culture. Absolutely. So as you can see here in the US, rates of opioid use disorder, prescription opioids, and heroin are higher among men than women, among young adults than older adults, and among those with lower income or education. Similarly, if you see here, you had a good segue, Uzi. Among US adults in 2012 and 2013, the prevalence of non-medical prescription opioid use disorder varied by ethno-racial groups. So 1.42% in Native Americans, 1.04% in African Americans, 0.9% in 0.96% in non-Latina white, 0.7 in Latinas, and 0. Latinos, and 0.16 in Asian Americans or Pacific Islanders. Rates based on household surveys. So rate based on household surveys. So imagine if I'm conducting a survey and I'm calling people at home, or I'm going to their houses and asking them that, hey, is there anybody with the disorder? They may be actually not a correct reflection. So the rate based on household surveys may underestimate national prevalence by omitting individuals in institutions and jail or prison whose rates are likely to be much higher. So meaning it's not an absolute science, there are variations within the society. Then I want to go back for a second to our last lecture just to once again refresh our memory that we are actually talking about mental disorders. So mental disorder is a syndrome characterized by clinically significant disturbance in individuals' cognition, emotion regulation, or behavior that reflects a dysfunction in the psychological, biological, or developmental process underlying mental functioning. So that is a DSM-5 TR, mental disorders. Then within the mental disorders, we are talking about substance use. We talked about substance use disorder. Substance use disorder is a complex condition in which there is uncontrolled use of a substance despite harmful consequences. Then opioid use disorder. This was just a refresher, these two slides on the last lecture, just to connect the dots for us. So opioid use disorder diagnostic criteria. This is what we've been waiting for 11 lectures. So here it is. You know that there are 11 diagnostic points, which are then divided into further categories. So the first four are the impaired control. So criteria one, opioids are often taken in larger amounts or over a longer period than was intended. So if you see actually the substance use disorder criteria, these are actually very similar, but instead of saying substances are often used, here you would see saying opioids are often used. So opioids are often taken in larger amounts or over a longer period than was intended. So either dose is increased or duration of usage is increased. Criteria number two, or criterion number two, there is a persistent desire or unsuccessful effort to cut down or control opioid use. Number two. Number three, a great deal of time is spent in activities necessary to obtain the opioids or use the opioids or recover from its effects. So again, this is impaired control. So the control is lost or compromised or impaired. Criterion four, craving or strong desire or urge to use opioids. So this is four. And as I showed it before, there may be some new members who came in just very quickly on the American Psychiatric Association's website. There is this page as well, which has all these 11 criterion or criteria on one page. When you are sitting next to your patient, you can actually go over this and check whichever one are applicable. So first four. Next three are the social impairment. So criterion 5, recurrent opioid use resulting in failure to fulfill major role obligations at work, school, or home. So that is social. Then continued opioid use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of opioids. And finally, in this group, important social, occupational, or recreational activities are given up or reduced because of opioid use. Saraswati says this doesn't differentiate between prescription versus street drugs. So I talked about the epidemiology before, but once the disorder is disorder, then the only important thing to keep in mind is tolerance and withdrawal are the disorders which, if somebody is on appropriate prescription usage, then they are not counted, but these remaining can still be counted. The question then will become, do you diagnose this as a disorder, or if they are actually dependent on this need, let's say they are cancer patient or they are a chronic pain patient, then you would not simply say that they are in this disorder. But this is the diagnostic criteria. Then risky use of substance. So criteria number 8, recurrent opioid use in situation in which it is physically hazardous. So even if it is a prescription use, you would realize that they should not use it in a physically hazardous environment. Continued opioid use despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by the substance. And the final two, the pharmacological criteria. So, of course, as last time, tolerance and withdrawal. And I have noted that many, many times. I'll do that once again. Tolerance and withdrawal by themselves in a patient who is taking medication or opioids with appropriate prescription are not counted as a diagnostic criteria. Or if they are present, they are not counted. So, tolerance, as defined by either of the following, a need for markedly increased amount of opioids to achieve intoxication or desired effect. And so I have done a set of lectures in this series about how tolerance develops. What is the mechanism of it? There are many parts of that mechanism that we actually do not know. And then there are some parts that we are aware of. So those wirings and neurological effects and receptor effects and chemical effects that we are aware of, I have done the discussion about that in detail. So number one, a need for markedly increased amounts of opioid to achieve intoxication or desired effect. And secondly, a markedly diminished effect with continued use of the same amount of the opioid. So this is very similar to the substance use disorder. And within that, the tolerance is that either the patient needs to achieve the same effect by a higher dose, or if the same dose is given, then the same effect is not achieved. So they are not tolerant. And look at the note here. This criterion is not considered to be met for those taking opioids solely under appropriate medical supervision. And then criterion 11, withdrawal. As manifested by either of the following, number one, the characteristic opioid withdrawal syndrome, refer to criteria A and B of the criteria set for opioid withdrawal. So there is a, if I go to the DSM-5 TR, within the opioid related disorders, if you see here, this is the opioid withdrawal. So to be able to say that somebody has withdrawal, the characteristics of the withdrawal syndrome can be seen in the opioid withdrawal, which is also present in this here. And I actually have a question for you. As we are doing the opioid use disorder, the next thing I was going to do is the management of it. Would you like that we talk about the opioid intoxication and opioid withdrawal as well? So I'll just give me your answers. So here, withdrawal. Number one, refer to the withdrawal points. Number two, opioids or a closely related substance are taken to relieve or avoid withdrawal symptoms. So here the patient is taking them, or the individual is taking them, opioids, to relieve or escape the withdrawal symptoms. And we did the discussion last time as well, that how the seeking behavior and avoiding behavior, the pain avoiding behavior, or this discomfort or withdrawal avoiding behavior appears. So Esther says, yes, if you could talk about both, that would be good. Okay, so noted. Now again, for criterion 11, this criterion is not considered to be met for those individuals taking opioids solely under appropriate medical supervision. So these are 11 criterion. There is, as I said, there is a PDF present on the ASA site as well. If you like, I can create this little PDF and then share that with this lecture too. And DSM-5 TR also has these. Okay, next. So that is the diagnostic criteria. Then is the severity. Do you remember severity from the substance use disorder? We have mild, moderate, and severe. So if you see here, presence of 2 to 3 symptoms out of these 11 that we just saw, you would diagnose them as mild. Once again, 10 and 11 by themselves under appropriate supervision do not count. Moderate, presence of 4 to 5 symptoms, then the withdrawal is moderate. Severe, did I say withdrawal disorder is moderate, use disorder? Severe, 6 or more. Then comes these specifiers. Remember last time we talked about these specifiers as well. For example, in early remission, in sustained remission, on maintenance therapy in a controlled environment. So that is these are the specifiers you can actually add. So in case of the opioid use disorder, you can specify that in early remission, that will mean 3 months or more, but lesser than 12 months of staying away from the opioids. So if you see here the exact text, after full criterion for opioid use disorder were previously met. So first you had diagnosed the patient or the individual at some point to say they have opioid use disorder. After you have diagnosed or someone has diagnosed, usually for this disorder, you should diagnose by yourself as well, even if somebody else diagnosed them and the patient came to you, you should do your own diagnostic routine. So after the diagnosis is done, then let's say now they're being managed. So after full criteria for opioid use disorder were previously met, none of the criteria for opioid use disorder have been met for at least 3 months, but lesser than 12. So 3 months or more, no further criteria is not getting met. That means they are recovering from it, and all those 11 are not, being met to be called disorder. And this is within 3 to 12 months. Then it is in early remission. You can put that with their diagnosis. If the remission, or if the same thing after all full criteria for opioid use disorder were previously met, none of the criteria for opioid use disorder have been met at any time during a period of 12 months or longer, then you would say in sustained remission. Now, in addition to these two specifiers, so one of them, right? So you won't say in early remission and in sustained remission, it is going to be one or the other. The next set of criteria can be added on. And so this one is going to be on maintenance therapy or in a controlled environment. So what is the maintenance therapy? This additional specifier is used if the individual is taking a prescribed agonist medication such as methadone or buprenorphine, and none of the criteria for opioid use disorder have been met for that class of medication except tolerance to or withdrawal from the agonist. So what are they talking about on maintenance therapy? What they're saying is, here you have a patient who is prescribed opioids, and so they are using opioids. And except the criteria number 10 and 11, tolerance and withdrawal, if these two are present, you would not count them. And if none of others is present, then it is not a use disorder, it is on maintenance therapy. But this is a specifier even with the disorder. So if you, let's say somebody is on prescription medicine, which, for example, methadone or buprenorphine, and they have the criteria is met for 10 and 11, you would not count them, and none of the other opioid disorder criteria, then you would say on maintenance therapy. Then in a controlled environment, this additional specifier is used if the individual is in an environment where access to opioids is restricted. So these are the additional, now I didn't read this part. This category, the on maintenance therapy, this category also applies to those individuals being maintained on a partial agonist, an agonist antagonist, or full antagonist such as an oral naltrexone or depot naltrexone. So these are the specifiers. So 3 things now: diagnostic criteria, 11, then 3 severity indicators, one of them, mild, moderate, severe, and then specifiers. In these two specifiers, they can come together. However, these two, only one of them will come in. Then the codes, the ICD-10 codes. So first of all, this is really important to keep in mind. What I'm going to read to you is this. If somebody has opioid use disorder, plus they have other disorders, opioid related disorder, for example, intoxication or withdrawal, then you will not code them for opioid use disorder. Instead, you will code them for the other disorder and then put the severity of the use disorder in the code as well. And I'll show you how to do that. So let me quickly read this. If an opioid intoxication, opioid withdrawal, or another opioid-induced mental disorder is also present, so you have a patient who has opioid use disorder, but they also have other opioid-related disorder, for example, intoxication, withdrawal, or other mental disorders, then do not use codes below for opioid use disorder. So let me just very quickly show you the codes. These are the codes. Don't use them if there is a additional disorder present. Instead, the comorbid opioid use disorder is indicated in the fourth character of the opioid-induced disorder code. So let me actually go here for a second. Let's say we're talking about opioid withdrawal. And then with the opioid withdrawal, there is also opioid use disorder. Then what happens is you take the letter number 4, this one, and this would then define what is the severity of opioid use disorder. So if I go back here, they've given an example. For example, if there is a comorbid opioid-induced depressive disorder and opioid use disorder, so the both are present together, opioid-induced depressive disorder and opioid use disorder, only the opioid-induced depressive disorder code is given. So you don't give them opioid use disorder code, just the depressive disorder code with the fourth character indicating whether the comorbid opioid use disorder is mild, moderate, or severe. So if I can go to my drawing for a second and say that, let's say you are doing F and then number dot some numbers. This number, the fourth one, if this is a combined or comorbid disorder where there is opioid use disorder plus some other opioid related disorder, then give the code for the opioid related disorder and use this letter number 4 to provide the severity of use disorder. So now let's go back here. For example, if you see here, F11.14. For mild opioid use disorder, this one in here, so F11.14, this one here is use disorder with opioid-induced depressive disorder. So here, this one says mild. So it can be, this is the depressive disorder, and this one is saying mild use disorder. Margaret says, in my state, there is no such thing as taking opiates for illness or for any reason. Yeah, there are actually reasons. So F11.14 for mild opioid use disorder with opioid-induced depressive disorder, or look at this, F11.24 for a moderate or severe opioid use disorder. So if you say 2 over here, then this will become, this would indicate severe opioid use disorder, and the rest of the code would indicate opioid-induced depressive disorder. So I hope that makes sense. Now, if the opioid use disorder alone is present and doesn't have a comorbid opioid-related disorder, then here are the codes that you'll use. Presence of 2 to 3 symptoms, mild. The code will be F11.10. Then within the mild category, F11.11 will be mild with early remission or with sustained remission. So these are the specifiers. So if you see here, F11.10, this one, the fourth letter is actually going to talk about the severity. If you see in the ones below, this one changes to 2, and that is severity change. And mild and moderate, sorry, moderate and severe are given 2. Mild is given 1. Then the fifth letter would change for specifier in early remission or in sustained remission. So here, F11.10 is mild, presence of 2 to 3 symptoms. F11.11, so 1 is a code, 0.1 means mild, and then 1 next to it means in early remission or in sustained remission. Then F11.20. So I think you can now decode this. F11 will be for the use disorder, opioid use disorder. 0.2 means moderate or severe. So that is a specifier, sorry, severity. And then the next letter will tell the specifier. So if it is 0, then there is no specifier. If it is 1, then there is early remission or sustained remission. Similarly, if you see here, F11.20, severe. So remember, 2 covers moderate and severe both. And then after severe, 6 or more symptoms, the fifth letter, if it is 0, that means there is no specifier. If it is 1, that would mean in early remission or sustained remission, or that would accompany that specifier. Jaila says you're breaking up. Am I breaking up for everyone, or just Jaila? Should I repeat this, or you are okay? Okay, so Jaila, it may be your sound, and what would happen is as I record this and upload it, you can probably hear this part again. Okay, so this is the opioid use disorder. So if I give you a quick test that if there is, let's say, opioid use, I just talked about it, opioid use depressive disorder, which is comorbid, that means combined with opioid use disorder, then will you give opioid use disorder code or not? You will not give the opioid use disorder code. Instead, you would use the comorbid code, for example, opioid-induced depressive disorder. And then the letter number 4 will be 1, 2, or 9. Actually, 0, 1, 2, or 9, but 1, 2, or 9. 1 will mean, so let me go back to my drawing. If it is 1 over here, that means mild opioid use disorder. Just this one will actually talk about the whole thing. Mild opioid use disorder. If it is 2, then that will mean moderate or severe opioid use disorder comorbid with this. For example, in this case, this is the opioid-induced depressive disorder. And if it is 9, then you would say that this is opioid-induced depressive disorder without the comorbidity of opioid use disorder. So 9 will mean opioid use disorder is not present, but the other one is present. If it is 1, then mild use disorder. If it is 2, then moderate and severe or severe. So I hope this makes sense. So let me actually quickly go here and show you opioid withdrawal. So for example, if you see here, this is opioid intoxication. So if you look at the code for the intoxication, if a mild opioid use disorder is comorbid, the ICD-10-CM code is F11.120. So here, And if a moderate or severe is present, then if you see here, F11.220. So this letter number 4, 1 means moderate opioid use disorder, sorry, mild. And 2 here means moderate to severe opioid use disorder, which is comorbid. And if it is 9 here, that means opioid use disorder is not present. The other situation is present, for example, opioid intoxication. And how can that happen, that somebody has opioid intoxication without use disorder? Yes. Somebody who just acutely was given accidentally or by choice use the opioid in large enough doses that it caused intoxication, but they were not using it all along before, so they don't have a use disorder, but just intoxication. In that case, the fourth letter will be 9. So I hope that this makes sense. And then are the diagnostic markers. So how do you diagnose these? So of course, the urine test, right? The most common one. So keep in mind that the standard urine test tests for morphine. And why is that important? That will become clear in a second. Urine toxicology is often positive for opioid drugs in individuals with opioid use disorder. Urine test results remain positive for most opioids, heroin, morphine, codeine, oxycodone, propoxyphene, for 12 to 36 hours after administration. Fentanyl and oxycodone require specialized tests that can detect these substances for several days after use. So standard urine test will not detect fentanyl and oxycodone. So for them, separate test is needed, and they can then see for several days. Similarly, methadone or buprenorphine or a combination of buprenorphine and naloxone require specific tests that can identify these substances after several days or to even 1 week or about more than 1 week. So urine test, but for fentanyl, oxycodone, methadone, buprenorphine and naloxone, special tests. Then non-specific markers, meaning they are not because of the opioid use disorder. So if you see here, or opioid use, the urine test is, you would see opioid metabolites in the urine. So that is directly related to opioid use. Here, these are not direct or specific markers, but they can be in addition to the urine test. For example, lab evidence of the presence of other substances, for example, cocaine, marijuana, alcohol, amphetamines, benzodiazepines, is common in heroin users. Then screening test results for hepatitis A, B, C viruses are often positive in injection opioid users, either for hepatitis antigen, signifying active infection, or for hepatitis antibody, signifying past infection. And I've done a separate discussion about how to look at hepatitis labs. Mildly elevated liver function. Test results are common either as a result of resolving hepatitis or from toxic injury to the liver due to contaminants that have been mixed with the injected opioids. So liver injury and liver function test. Then HIV is also present in injection opioid users. Subtle changes in cortisol levels, secretion patterns, and body temperature regulation, which we did a discussion about that in the previous lectures. So subtle changes in cortisol, secretion patterns, and body temperature regulation have been observed for up to 6 months following opioid withdrawal. So these are non-specific markers, but markers, indicators, or labs, urine test are the specific ones. So this is the discussion. Once again, the primary source, and I specifically adhered to DSM-5 TR so that we are just very, very clear for these messages. So because of that, the primary source is DSM-5-TR. Thank you very much. And next time now, I was planning to go into the management, but maybe we'll do intoxication and withdrawal as well, and then get into the management. Thank you very much.